I'd like to just say good evening, everybody, or good afternoon, depending on where you are, and welcome to the Boston University School of Medicine. For those of you who don't know me or don't recognize me without my beard, I'm Greg Grilloni, the chair of otolaryngology here at Boston University School of Medicine. And I just want to say that we are so honored and delighted to be hosting the inaugural Edelstein lecture on professionalism and ethics in medicine. But honestly, I can't take any of the credit for establishing this lectureship because all of that credit goes to Ken Grunfast, my predecessor and mentor, and of course to the Edelstein family. And so before I turn the podium over to Ken to say a little bit more about the history behind this lectureship, I just want to let everybody know that you are able to ask questions in the chat room or using the Q&A function, and we will hold those questions till the end of the presentation, and then we'll go ahead and answer them. So with that, I'd like to turn the virtual podium over to Ken Grunfast.
Good evening, everybody. Thanks for joining us. So this has been kind of a difficult year, and I think it's going to be nice to hear something this evening that I think is going to be uplifting and certainly thought-provoking. And the talk that Dr. Persky will give is made possible by a generous donation from the Edelstein family. So let me just tell you a little bit about the Edelsteins. I've known David for more than 30 years. I first met him when he was at the Manhattan Eye, Ear, and Throat Hospital. And then after I came to Boston in 1999, I had the honor of providing medical care for David's father, Alan Edelstein. And through connections in our community, I came to know Sybil, Alan's wife, and Marcia, David's sister. The Edelsteins received much of their education at Boston University. Alan, who unfortunately died about a year and a half ago, was a graduate of the BU School of Management and later the BU School of Law. He founded the Edelstein and Company accounting firm that continues to exist today as one of the most highly respected accounting firms in Boston. David, my friend and colleague, was a member of the Boston University School of Medicine, which we hereafter refer to as BUSM, in the class of 1980. He's the director of otolaryngology at the Northwell Manhattan Eye, Ear, and Throat Hospital. He's chair of otolaryngology at Northwell Lenox Hill Hospital. And quite importantly, he's a past chair of the Board of Governors of the American Academy of Otolaryngology Head and Neck Surgery. And David is continuing to serve now on the BUSM Deeds Advisory Board, as did his father. Marcia was president of the BUSM class of 1978, and she's a past president of the BUSM Alumni Association. She's a member of the BUSM Alumni Executive Committee, and she has had a successful career as a pediatrician, and she's now retired from being a pediatrician. Throughout most of her years in practice, she volunteered to teach pediatrics to medical students in a primary care clerkship. And she currently volunteers with nonprofits in the disability awareness arena. Sybil, Alan's wife, the mother of Marcia and David, was a social worker. And she's kind of been the glue that held the family together and provided the support and encouragement that enabled all of the Edelsteins to accomplish so much. So as I look back on my interactions with the Edelstein family that I've come to know well, I can think of three words that best describe this family's relationship with the Boston University School of Medicine. First, gratitude. And let me tell you, the world would be a better place if more people felt more gratitude. Second, loyalty. The Edelsteins have been unwavering in their continuous loyalty to the Boston University School of Medicine. And the third word is action. They don't just talk and they don't just hang out in the wings or in the background. They've been active in helping all of us at the Boston University School of Medicine. They stayed involved, showed up, and helped financially. So finally, I just want to let you know that the talk sponsored by the Edelstein family that Dr. Persky will be giving is only one part of a larger initiative here at the Boston University School of Medicine, aiming to address issues pertaining to professionalism and ethics. 4 years ago, we established the Professionalism Resource Service that provides mentoring, coaching, and helps to arrange to bring in consultants and guest speakers who can assist students, faculty, and support staff to know what's expected of them in the realm of professionalism. So I am really grateful to the Edelstein family for your loyalty to the Boston University School of Medicine and your support of activities such as the upcoming lecture. Thank you so much. David, can we hear from you?
Yes, actually, Marcia.
Yes, right. Thank you, Ken. My brother David and I want to welcome you all to the first annual Alan and Sybil Edelstein Lecture on Professionalism and Ethics in Medicine. We set up this lectureship at the BU School of Medicine in memory of our father and in honor of our mother, Sybil, who turns 94 this week. Boston University has played a big role in our family. Alan was a graduate, as Ken said, both of the BU School of Law and the BU School of Business Management. He served as head of the Alumni Council for the School of Management and on many committees at the law school. After he retired as a certified public accountant, he served for over 25 years on the Board of Visitors at the medical school. Our parents were strong proponents of education, but beyond acquiring knowledge, they were always concerned about how best to apply it in practice. Ethics and discussions of moral dilemmas were always front and center. It was therefore fitting when I retired from pediatric practice that I taught a course to medical students on medical dilemmas. It's our wish that the issues that Alan and Sybil felt so strongly about be given more prominence in medical education to stimulate the kind of thinking and perspective that will lead to continuing improvements in the professional delivery of healthcare. And now it's my honor to turn the program over to my brother, David.
Well, thank you, Marcia. Obviously, Greg and Ken, since this is the first lecture, I have some brief comments before I introduce our speaker. These discussions on professionalism and ethics with my parents became an essential part of my leadership role in otolaryngology. My father would always ask if I had trained not just the best doctors, but ones who were the most professional and the most ethical. In the 30 years that I interviewed medical students for several residency programs, including my own at Manhattan Ioneer, now a part of Northwell Lenox Hill, we always had one room which asked ethical questions. I don't think I ever took a resident who failed that room or who didn't understand the issues raised. The questions raised including what a young doctor or medical student would do if they found an impaired physician at work or witnessed a patient harassing a team member in the emergency room. Unfortunately, these are not abstract questions, and I'm proud that we asked these questions starting in the 1980s, long before courses on these subjects became standard at every hospital annual training program. Today, as I sit on the BU Dean's Advisory Board, my parents would be pleased that Dean Karen Antman and Assistant Dean Ken Grunfast spend significant time during our meetings discussing professionalism and ethics in medicine. This is something BU lives daily. As first-year medical students at BU, Marcia and I both recall taking required social medicine, where we read books from Victor Fuchs about who shall live, or from Rene Dubos on man adapting. This was our introduction to ethical dilemmas in medicine and in the physician's unique role in society as a professional healer. So just to conclude this portion, during the COVID crisis today, we're faced with many acute ethical decisions on care, and society looks to healthcare professionals, like doctors, for leadership, professionalism, and calmness. This is not an abstraction. But for tonight, it's with great pleasure that I introduce Dr. Mark Persky, whom I've known for over 37 years. He's a well-known expert in head and neck surgery and is professor of otolaryngology at the NYU School of Medicine and the former director of Head and Neck Cancer Center at NYU Langone Medical Center. He's a former head of otolaryngology at the Continuum Hospitals in New York. He's had many leadership appointments with a 30-page CV or longer, with the most recent being past president of the Triological Society, our most elite academic otolaryngology organization. As an old friend and colleague, I can also say that he's one of the most ethical and professional physicians and surgeons. It's appropriate that he be the first to give the lecture entitled Professionalism, Patient Trust. Mark.
Well, David, thank you for that very kind and very gracious introduction. I do appreciate it. It's my distinct privilege to be the first lecturer for the Allen and Sybil Edelstein Lecture in Professionalism Ethics. And again, I do thank you so much. I thank everyone who was involved with the decision process to choose me. And hopefully I'll do well by this inaugural lecture. So I think we should get started as much as possible. And what I actually did is some research into the Boston University program. And we know that I give my greetings and thanks to Dr. Garoni and Dr. Grunfast, your present and your past chairs, who represent two acknowledged leaders in our specialty, and who are also known for their professionalism and demeanor and their commitment to education. So I thank you all, and I also well realize that there have been a huge number of graduates from your program who have assumed major roles of leadership within our specialty. And in addition, I went through the history of the program a bit too, and it's quite fascinating. The first chair of your program is Stuart Strong, and his colleagues, Dr. Vaughn and Dr. Yako, who are known for their institution of and development of carbon dioxide laser in the treatment, especially the transendoscopic treatment of head and neck tumors, an impact that exists to this day. There are a few other professors who are associated with your program, who I personally know and who really instituted the professionalism that I think that emanates from your program. And I'm just going to review them very quickly. One is Dr. Marvin Freed, a friend of mine, as well as a former chair since I was a member of his department at Einstein College of Medicine, otolaryngology. And Marvin has certainly performed well at your institution as well as at Einstein. He is also well known for his contributions to laryngology and well known for his formulation of the simulation of surgery in otolaryngology, which has assumed a real important aspect in the training of our residents. Dr. Gerald Healy was part of your program early on, and again, a force within otolaryngology with a very strong personality, and ex-chair of otolaryngology at Boston Children's Hospital, so I'm sure you're aware of that, as well as being quite unique as being the only otolaryngologist who has become the president of the American College of Surgeons, and deservedly so. And last, but certainly not least, is my very close friend, Dr. Stan Shapshay, who was also at your program before heading to Tufts University. And Stan has a national reputation for his commitment to resident and medical school education. He is presently up in Albany, and believe me, he's well appreciated up there. He too has certainly added to the laryngology literature, as well as to the use of carbon dioxide laser within otolaryngology. So you have a reputation of strength and of professionalism, as well as ethics, by the history that you certainly display here. So let's get on with the presentation. If you look at the definition of professionalism as contributed by Merriam-Webster, there's two definitions that come to mind, that come to our attention. Number one, professionalism is defined as characterized by or conforming to the technical or ethical standards of a profession. I think we can agree to that. The second definition is exhibiting a courteous, conscientious, and generally businesslike, or in our world, medical-like manner in the workplace. And I think that indeed that too can be understood as part of the definition of professionalism. So let's continue on with the presentation. First of all, I have no financial disclosures, but I do have other disclosures to mention. And that is that I have a true and sincere personal investment in the success of my residents. They, as far as I'm concerned, are as much a part of my legacy as my own children. I've gone through many generations of medical residents, and hopefully I've provided them some element of tradition of showing them what I believe to be is exceptional patient care. And I think many of them have followed that legacy. And perhaps too, I represent an anachronism, because in many ways, and perhaps I'll be demonstrating those ways as we get along with this talk, I continue to adhere and to maintain select medical traditions that are tried and true throughout the years that I believe establish a certain element of professionalism. And professionalism is something that's so important with how we treat our patients. So I'm also now going to give a certain scenario that it's actually a bit of a story. There are a long line of souls waiting to get in through the gates of heaven. And all of a sudden, someone with a white coat bypasses the entire line and enters the gates. And one soul taps the other on the shoulder. He says, "Do you believe that? I don't understand. How could he possibly do something like that?" And the other soul turns to him and says, "Oh, don't worry. That's God. He thinks he's a doctor." Well, the perception of that, of doctors perhaps being self-privileged and self-serving, was part of the layman view of the medical profession to some extent. We were dictatorial. We dictated exactly the way they should be treated, and there really wasn't very discussion as far as any alternatives. But that's changed. Fortunately, it's changed. And I think that public now, especially during this COVID crisis, truly realizes the commitment of the medical profession to taking care of patients, even at their risk of their own health. And I'm talking about all generations of the medical professions that have been called to take care of these patients and have done so without any question. So I think that the perception of doctors, as I first described, is fortunately not the way they're viewed by the public at this point, but it's certainly something that did exist in the past. You know, in real estate, there are three ways to get success, and that's to deal with location, location, and location. In medicine, my three modes of success are honesty, honesty, and honesty. The first form of honesty is with doctors and their patients and their family. When we discuss issues with a patient and their family, we are truthful. We do present to them all the facts, all the options, and all the potential complications that they may incur along the way. And we include the family in the discussion, or should anyway. And that's my first tier of honesty. The second one is honesty of physicians with their colleagues. Physician colleagues and house staff, being honest with the physician actually makes you form a very special relationship. And even if you criticize a physician colleague and it's done appropriately and it's done not to define any sort of weakness, they can accept that. And honest criticism is important as far as our profession is concerned. Certainly, we have to promote honesty towards the office staff and the hospital staff. Personally, every time I leave the operating room, I thank each and every one of the staff in the operating room for thanking me with that case, for the success of that case. And a thank you goes very far in establishing honesty and true spirit with the staff. Remember, they are part of your team, and they are just as important as you are in many ways in making sure that the patient has a smooth course. And even we should be honest with insurance companies. I know there are various ways to submit many of our surgical and office codes, but it's important to be honest, because I found out that if any person is dishonest in any area of his life, professionally or personally, there tend to be other areas of this person's life and extension that they're dishonest in too. So if you have a blanket of honesty that you deal with, I think that's exceptionally important. Then there's the most important tier of honesty, and that's honesty with yourself. You have to assess if indeed you are performing your duties in an ethical and moral way. And that is incredibly important in establishing your reputation and as establishing the relationship that you form with a patient and their family. And that requires a very critical self-assessment. And doctors often are not very good in self-assessing themselves, especially surgeons for some reason. But it is quite important. And what does that involve? Well, the first step in a critical self-assessment is to realize what your surgical abilities and competence are, and also surgical inabilities. Sometimes surgeons handle cases that are beyond their ability, that they are beyond their education, beyond their experience. And surgeons should realize, indeed, if they are going into that direction, because that only leads to harming patients, and that's what we want to try to avoid. In addition to handling surgical issues, we have to be able to handle the complications of that surgery or any non-surgical treatment of patients. That's part of a critical self-assessment. If you find that you are unable to really get an ideal approach to the type of surgery you do and the handling of these complications, you have to perhaps question as to whether you should take a step back and maybe not perform these type of procedures. Also, it's not a blow to your ego to refer to more experienced surgeons in particular pathologic issues where you just may not be experienced because of a particular disease that you don't have a common experience with. And referring to more experienced surgeons is part of the critical self-assessment that indeed you do, under the proper circumstances, refer to more experienced surgeons. Medicine evolves, and so does the information of medicine, so does the knowledge of medicine. And you have to realize and question yourself as to whether you're attending conferences, courses, grand rounds, and whether you read, observe, and question all the developments that occur in medicine to keep up with what's accepted practice as medicine does evolve. Experienced physicians develop a certain clinical intuition. It's almost like a sixth sense. And that means, as far as I'm concerned, that even if tests don't indicate what you think is there, you have to find out if your intuition is telling you that there is a potential problem with this, to go a step further. What I mean by that is I'll have a patient who will come to me with a tumor of the oral cavity. As you know, I'm a head and neck surgeon. I'll biopsy it, and for whatever reason, the biopsy comes back to be negative. It comes back to be benign. However, if I know through my experience, through my intuition, that indeed this does not represent a benign tumor, I don't trust that test. Don't take the easy way out and trust a test that doesn't agree with what your intuition is. I take another biopsy until I get the test that indeed proves that I was correct with my intuition. So don't necessarily go by a first test that documents a benign disease or an event that's not going to be harmful to the patient. If you think that there's a problem with that, then you have to go even further. Another issue is that unfortunately we learn more from our mistakes than we do by our successes. We have to realize this and use it to our advantage to help future patients. Everyone makes mistakes, and certainly in surgery, we make mistakes, and indeed we get complications. But we have to recognize that and use it to our advantage and use it to the patient's advantage. And then there's the issue of the aging surgeon, the surgeon who perhaps is operating beyond his peak. He may have waning surgical skills. His hand-eye coordination may not be as good as it should be. His cognitive states may not be as acute as they used to be. These are very difficult for elderly surgeons to admit. And it's even up to the chairs of department that have the responsibility sometimes of bringing that to their attention. And that involves a significant amount of understanding by realizing that it's the aging surgeon does have an issue with recognizing his own drawbacks due to his declining state of surgical skills. What do patients want? Well, Healthgrades is a website that patients use to declare their approval of the doctor that they're seeing or their disapproval. And evaluation of Healthgrades and what patients state as far as their experiences with physicians have come up with a few items that we should pay attention to. Patients most complain that the doctor doesn't spend time with us. The doctor seems to be somewhere else, or else she's rushing us, and we really don't appreciate that. And I think we can understand that because sometimes we are rushed with many different things. The second thing they say, the patients say, is the doctor doesn't listen to me. He rushes me and he doesn't answer my questions thoroughly enough to make me understand what my condition is. And that's something that has to be addressed too. In addition, they say, we will very much want to establish the level of trust with doctors, but sometimes these particular issues interfere with establishing that level of trust. So we have to address those particular issues, and I do in a very point-by-point specific way. But one thing that patients don't realize is that our time and demands on our time is being demanded in many different directions. Here we see the physician in the middle being courted by the different areas that demand his attention. Certainly the patients are part of that, and we just discussed that. But what about academics? We in academics, and I've been in academics my entire professional life, there are certain expectations of us that require time. We're required to publish. We're required to present. We're required to mentor. We're required to teach. We're required also to keep up our practice enough in this new world of somewhat corporate mentality to keep up our revenue to cover our expenses and our salary. That all takes time. In addition, on the other hand, we have insurance companies requesting some of our time. Certainly our office staff spends an enormous amount of time getting approval for tests or surgery from insurance companies. But I've got to tell you that one of the most frustrating experiences I have is the time I have to spend on the phone with a peer-to-peer review insurance company doctor to justify a test or a procedure that they have no idea what I'm talking about. And it takes time. It may take several peer-to-peer reviews in order to obtain what you need in the security of the patient for what they need. But that too is another time constraint that we have. And the fourth one are government regulations. We have to justify everything we do. We have to document everything we do in order to get payment from government institutions, Medicare, Medicaid, and the government requires a certain element of, again, documentation that takes time to submit. And these are all part of what a physician has to deal with. Well, patients, they don't know how we're being drawn and four-quartered like this. And you know what? They don't care. And you know what? They shouldn't care, because they deserve our attention. And that's something that we have to give them. You know, there's a very simple formula for success. Do unto others as you would like to have done unto you. In other words, put yourself in the patient's shoes. What would you expect if you had the same problem that they present to you with? How would you want to be the physician to be related to you? Well, there's several ways to deal with this. And I have a very smart wife, okay? She's wonderful. And she said to me once, you have only one chance to make a first impression. Now think about that. It's very simplistic, but it's very true. And if you make a poor first impression, it's very difficult to get beyond that frequently when you're dealing with patients and their family. So with that in mind, the first impression counts. Well, what's the patient's first contact with you? Phone call to the office. Ideally, if you could have a human answer rather than a long phone tree for them to go through to get a human to answer, that would be ideal. It may not be practical in this day and age, but to get a human on as quickly as possible to address the patient would be ideal. That person who they speak to is an extension of you. They represent how you perceive patients and how responsive you are to them. So the person who's on the phone should be responsive to questions. They should be attentive to the patient, and they should review any necessary details that the patient requires on a first consultation basis to make the consultation as effective as possible. The patient should be advised to get the results of the biopsies, to get the results of any imaging studies, to get the operative reports if another operation was involved previously. And I must admit that I never trust interpretations. I always, not only do I want the results of the biopsy and the imaging studies, but I expect the CD of the imaging study for my review, and I expect the biopsy specimen itself for my pathologist review too. It's something that adds to the details of making sure that indeed everything is agreeable or agreeing with what you think is necessary to make the final judgment on how the patient is treated. Patient comes to the office. That's the next impression that they come to. As you can see, I emphasize clean. A medical office has to be clean. In addition, they have to be respectful of the patient's needs and patient's privacy. Some of these patients have undergone head and neck procedures that may have involved some form of functional deformity or cosmetic deformity, and they need a bit of privacy just to maintain their demeanor and to make sure that they feel comfortable being in the office. The patient should get the sense that indeed they're in a professional atmosphere, people who are confident in what they're doing, they're polite, and indeed sympathetic. Well, then the doctor comes into the office. Now we get our first contact with the patient. And I must admit, I'm almost always late. I have a busy practice, not that I want to make excuses, but I'm almost late, always late. And the first thing to do that I do is to apologize if you're late. It's important to realize the patients don't want to realize that you think your time is more important than their time. And by apologizing, you're indicating that indeed you are sorry, you do respect their time, and in fact, you'll give the excuse exactly why you're late, and which is exactly what I do. So I apologize if I'm late, and often it can defuse the situation because some patients get quite angry and quite uncontrolled when they get to be too late. Sit down, you pay attention to the patient. Again, focus on listening. It's important to hear the patient, not only what they say, but how they say it. You'll get a better idea about what type of stress they're going through by listening to what they say and how they say it. Don't rush. don't lead to miscommunication. Sometimes you may have to direct the patient's history to focus a bit more on what you want, but you can do it in a very gentle manner. Because rushing, not only does it lead to miscommunication, but it leads to more mistakes, and ultimately, it affects the MD and the patient relationship. And we like to try to avoid that. We have to make sure that the patients have full faith and confidence in us when we decide, or when they decide that we are the ones to control the care, to provide whatever surgery or medical treatment that they need. We get interrupted all the time, of course, but I try to avoid as many interruptions as I can. Certainly, if it's an emergency that requires my immediate attention, the patient can understand that. And the only other thing that I allow for interruptions are calls from referring MDs who may have a patient in their office with an issue that they're not familiar with, but which I am. And they might be an urgent thing for these referring MDs, and I do take their call. You certainly want to be available to referring MDs under those circumstances. And again, if that does happen, I'll explain it to the patient, because they may have been previously the patient in that situation in their primary care physician's office. So I think it's something that is warranted. I always return calls the same day or early the next morning, depending upon my schedule. If it's not I who returns the calls, then it's certainly my nurse practitioner or my physician's assistant. I have a wonderful physician extender group here, and they're sympathetic, they're bright, they're willing to learn, and I allow them to take many of the return calls to the patient. And indeed, they do a wonderful job on that. I'm very formal. I refer to the patient as Mr. or Ms. or Mrs. I avoid terms that I find with a lack of taste, that some of the other terms that some physicians use. So I'm always very formal with the patients. If it comes to biopsy results, I discuss those directly with patients. I think it's important, even if the biopsy is benign, and certainly if it's malignant, the patient wants to hear it from the physician, because they're going to have questions immediately after getting this, be it benign or a malignant result. And I'm there to answer those questions. So all patients with biopsy results, I call. When I discuss surgery with patients, I almost always insist on having family or close friends present. And the reason for that is that discussion of surgery is very agitating for a patient, especially the elderly patient, and especially those who don't understand certain elements of medicine. So when I'm discussing surgery, sometimes the patient, I can realize, is focusing on what I said several minutes ago and really hasn't absorbed what I've said since that time. With family and friends present as their advocate, they can always discuss this with the patient, even after the office visit, and indeed make the patient realize that the doctor was patient, was discussing very important points, and did indeed have the answer to many of his questions. Not only that, but these family and friends can ask very pertinent questions that the patient themselves may not have thought about. So having family and friends present during that type of discussion, I think, is quite valuable. Whenever I propose surgery or any other type of extreme type of or involved type of therapy, I bring up the topic of getting a second opinion. I mean, here in New York, when you propose surgery to a patient, it's not uncommon for them you can tell they're thinking, oh, I'm going to go get a second, a third, or fourth opinion about this. And I expect that. I have no problems with that. And also many patients have done their websites searches, their Google searches about whatever they have, and they think about perhaps going elsewhere for additional opinions. So I bring up the topic. I tell them that it is my pleasure to give them whatever they need to get an informed second or third opinion. I'll give them all the results of all the tests and make sure that whoever they see has all the information available to come to the correct conclusion on how to treat these patients. And in fact, most patients do still come back to me. And I've been very fortunate in that way. Another thing is not to be professorial. Don't talk down to the patient. It's a very fine line between being confident and not being arrogant. And that's a line that can vary from patient to patient and vary from physician to physician according to his personality and how he presents things. But the patient does want it to indeed have a confident physician, but not an arrogant one that dictates the terms to them. And that too is very important in establishing the relationship that you may have to rely on and that the patient relies on to take them through some very tough treatment or tough surgery. And it's something to realize. As I'm explaining things to the patient, I always ask if the patient has any questions, not at the end of my explanation, but after a certain period of time of discussing things, I ask the patient, do you have any questions? He may or may not, and then I go on with the discussion. Very often, if you leave your questions or ask the patient if he has any questions to the end of a more detailed discussion, he may have had questions at the very beginning, but he can't remember them because he's so upset about what you told him as far as any treatment options. So it's important that as you give a prolonged discussion to a patient, that indeed you ask along the way, tell me, do you have any questions about what we've discussed so far? I think that's important, and it makes the patient feel confident and comfortable too. Don't badmouth other doctors. Don't be a Monday morning quarterback. Everyone has complications, and it doesn't reflect well on your bad-mouthing them or being critical of them in front of patients. So it's something I never do, and I think that you just don't gain a good reputation with your colleagues if indeed you have a habit of doing that. And never, ever abandon a dying patient. That's something that I've learned over time, that when a patient gets beyond the treatment phase and things are very helpless, do not abandon them. Try to make their process of leaving this world as comfortable as they can, as pain-free as they can, as much for the patient as well as for the patient's family. You have to be there for them to help support them emotionally and provide whatever care you can to make their passage as easy as possible. So this is interesting. When I discuss all the treatment options with a patient, and again, I make sure the patient is aware of all the options. They could be surgical, they could be non-surgical. Often there's options involving both of those. I give them all the options, but I do not, at the end of that discussion, ask them what their preference is. What I do before asking them of their preference is tell them what my preference is. They are there for your experience and for your knowledge. And you have to make sure they realize the options and they want to know what your decision is as far as the best option for them. And then they have the final word as far as discussing what their preference is, what their option is. But I give them my option first before I ask them to make the decision. And they may need time to actually discuss that with other physicians or their family before coming to that decision. But it's something, that's the way I handle it with patients. Atul Gawande is one of the surgeons in Boston. I'm sure you're aware of him. He's done lots of publishing about patients, and he writes this in one of his books. The new orthodoxy about patient autonomy has a hard time acknowledging an awkward truth. Patients frequently don't want the freedom that we've given them. One study found that although 64% of the general public thought they'd want to select their own treatment if they've developed cancer, actually only 12% of newly diagnosed cancer patients actually did want to do so. So that fits in with giving my patients my opinion before asking them what their opinion is. And I think this is a very astute observation on Dr. Gawande's part. So when I was developing this discussion on ethics, on professionalism, I said, you know, let me see what the experts think about this. Let me see some professors of bioethics. And indeed, I found one, Dr. Albert Johnson, who is a recognized expert on bioethics. And he breaks things down into 4 categories. And I wondered if I addressed those categories during this discussion. Number 1, he discusses autonomy. Allow patients to make informed choices of treatment. Well, we discussed that. Indeed, that's very important. Number 2 is beneficence, to enable physicians to make decisions that benefit the patient. Well, exactly, we've discussed that too, to make sure that physicians are enabled to do this and that they have the experience and expertise to do so. Number 3 is non-maleficence, causing harm that outweighs any benefits of treatment. That's something that obviously should be avoided. When we talk to patients about the options of treatment, we should have a scale in our head, okay? On one side of the scale is risk, and the other side is benefits. And we have to try and go towards the obviously the benefits type of the benefits portion of that scale, to treat patients where they're going to hopefully respond to our treatment and hopefully cure them of whatever is causing these issues. That doesn't mean that there aren't certain risks involved, but we have to try and outweigh the benefits versus the risks when we propose a form of treatment. And the 4th thing, which I think we've discussed, is respect for patients and their families. And certainly the patients and their families, the patients rely on their families for the support, and they deserve our attention, as do the patients. So there's no question as that, which we have discussed, which I was glad to see that we have covered these particular areas. The electronic health record. Okay, it has advantages and disadvantages. And it certainly has evolved to be very helpful, actually, I find it, in finding out the comprehensive history of patients. I can go into other doctors' records and find out exactly what they've done and said about patients. And it's very helpful in that respect. But there are issues, there are certain disadvantages. And one of the issues is that the electronic health record, as manifested by a computer in the examining room with the patient, only acts as a wedge between the physician and the patient. The patient complains that the doctor has one eye on the computer and one eye on the clock. And indeed, we see physicians who respond just like that when patients come into the office. They're busy inputting all the details and all the necessary information, and sometimes they don't focus enough on the patient. So Dr. Grubman, who's also a physician in the Boston area, states that it blunts communication, it fosters mistakes, and it ruptures the partnership between patient and physician. So I'm, as I said, a bit traditional. I never, ever have a computer in the examining room when I'm discussing things with the patient. Now, I pay the price for that, because at the end of office hours, I have to submit all this data into the computer, and it's time consuming, but that's okay. I've done what I've had to do, and the patient has received my attention and my focus, and I've accomplished what I want. So there's no way that anyone can be a professional and show the necessary professionalism to family, to colleagues, to patients, unless they have a major element of personal fulfillment. If you're not happy doing what you do, if you're not consumed, especially in medicine, in doing what you do and enjoying it, you're not going to be as professional as you should be. And perhaps you may not be as ethical, but certainly it'll take its toll. You have to ask yourself certain questions. Do you enjoy going to the office? Do you enjoy going to the operating room? Do you enjoy teaching? I've been teaching for over 40 years, and I must tell you that's the greatest joy in my professional life. I hate to say it in front of residents, but actually I think I've learned more from residents than they've perhaps learned from me. They challenge me in a very respectful way, and I absolutely adore teaching the residents and seeing them progress throughout the years and becoming experts and wonderful surgeons and physicians. Do you enjoy helping patients? And are you able to bear the weight of the decisions that you make about patient care? I have dealt with very sick patients, patients with advanced disease. I've subjected them to, as I said previously, operations that affect significantly their quality of life, that affect their how they look and affect how they function. And I must admit, with time, I internalize their pain, their issues, more than I did even in the past. But I'm able to bear it. And I think that's part of my responsibilities and part of my being a physician. And then the other sense is balance of professional and personal life. You should have a personal life outside of your being a physician to enjoy certain things outside of being a doctor. You have children, you have spouses, you have family, friends, and yourself. Take advantage of that. In other words, smell the roses. Here you can see me with gathering my family in the left upper corner. Everyone's smiling, including myself and my wife, and we have great times together. Times when you can focus away from the medicine and enjoy what's going on in your life. I have times when you can see in the other pictures, I spend a little time by myself, perhaps in a bit of a dangerous sport. And here's my wife and I going down the rapids and enjoying ourselves, and me with the kids skiing in Vail. Smell the roses. You need time to spend with your family to enjoy your outside life and be as fulfilled that will actually carry over to your professional life. And simple conclusions to this discussion. Do unto others as you would like done unto yourself if you were a patient. Anecdotally speaking, I speak to doctors who have undergone severe surgery, severe medical issues, and they come back after this and they say, you know what? I think I'm a better doctor because I know what patients want now. And I believe that. Do what makes you fulfilled, do it well, do it honestly. So I again want to thank everyone for allowing me to be the inaugural lecturer for this, for the Edelstein Lecture in Professionalism and Ethics. I thank you for your invitation, and I certainly wish you all a very happy and safe Thanksgiving. And I'm certainly willing to take any questions, if indeed there aren't any, that should be addressed. But thank you again.
Well, thanks, Dr. Persky, for that absolutely wonderful lecture. I really enjoyed it, and it was really stimulating. And I would invite everyone here to submit any questions to the Q&A or to the chat. Either one is fine. And there is one question that I'll start with, and please feel free to populate any others. And so the first question I have here is that traditional physicians never advertised. Now we see physicians all over social media glamorizing surgeries and patient outcomes. Does social media enhance or detract from professionalism?
That's an excellent question, and certainly very timely too. I must admit, being, as I said, a traditionalist, I just don't move forward and don't go forward and don't promote the self-promotion that these advertisements bring. I think that it's too much selling yourself in a way that I find a bit offensive, in all honesty. So I'm not into the self-promotion. I'm not into advertising. If patients don't find it offensive and think that it brings them to the proper physician for their care, then that's fine with me, obviously. But I don't know exactly whether the more sophisticated patient necessarily goes by what they see on television or hear on the radio.
Great, thanks. There is another question here to all panelists, and that is, how do you think about diversity and inclusion on this topic of professionalism?
I think that's an important topic, and it's one that I fully support. Actually, being past president of the Triological Society, I actually did indeed promote the idea of diversity within our profession, within our specialty, and within our society. And I think that's something we're trying to continue to promote. And it's important to realize that that indeed should reflect one of our main focuses during the coming years, because there is a lack of diversity in certain areas of medicine, and perhaps in all of medicine, that we have to recognize and correct.
Good. There's another question here. Wonderful talk, Dr. Persky. How do you balance one's growth as a surgeon and acquiring new experience with the fact that there is usually a more experienced surgeon on a particular case?
Well, but that's where the teaching attitude of the experienced surgeon enters into the picture. In other words, there's a gradual increase in the ability of residents and young physicians to perform more complicated surgery. And there's a learning curve. And I always say to my residents, you guys, you want to learn how to be surgeons before you learn how to be good first assistants. A first assistant will give you a lot of experience in how to becoming a good surgeon. And it's the same thing if you're dealing with an experienced surgeon or physician who's there to teach you. Indeed, he has to give you the responsibilities that are matched with your abilities to perform the surgery in a safe manner. And that's where we try to promote that amongst our faculty. We have mentors for all of our residents. We're assigned to each of the residents, and I happen to be a mentor to several of our younger physicians on the faculty. And the whole idea is to make sure they follow the element of education, teaching, shared responsibility, and trying to teach the residents to learn to gain the experience and respect that they need to go forward.
The next question is, how do you manage the difficult or angry patient? Any tips on how you handle them?
There are angry patients and there are angry patients. There are some angry patients you may be so angry they can almost get physical with you, and those patients you want to stay away from and basically even call security. But the best thing to do is not to be confrontational. I listen to them. I find out why they're angry. Some patients have a right to be angry, or some patients are undergoing very stressful periods, and you have to forgive them for their anger. And some patients are just angry at everyone, and those patients you can't get very much leeway with. But it's a matter of listening to patients, and they may have a reason, and a very real reason for being angry, and you have to address that. The first thing I do is I listen, and I don't counter what they're saying.
Okay, thanks. We have another question here from Dr. Shapshay, who says, great lecture, Dr. Persky. In addition, how has COVID affected your present management of patients? Example, how not allowing family members into the exam room and the burden of PPE, how has this changed your practice? Dr. Persky, I think you're muted. Can you unmute? Dr. Persky, we can't hear you. I think that you're muted. Did we lose Dr.? Give us a minute here to get Dr. Persky back.
I'm so sorry. Do you hear me?
Yes, you're back. Thanks. We lost you there for a minute. The question was how has COVID and the limitations on families and PPE affected you?
Well, it's affected everyone personally. I mean, certainly we have to maintain our social distance and using PPEs. And I think that we cannot underestimate the infectious nature of this disease. I got to tell you that as large a family as I have, I'm not having anyone over for my Thanksgiving, and nor are they. I think it's very important. And what the other problem is that patients are under stress given their medical situation, and now there's additional stress and isolation, and we have to address those issues too, to make sure that you're always available and that the proper precautions have to be taken. They have to realize when they come into the hospital that understandably, they may think that they're being exposed to more of a COVID positive situation, but that the hospital has been wonderful in maintaining the proper precautions to avoid their getting infected.
The next question is, how do you balance the moral injury associated with trying to meet conflicting expectations and objectives between those of the patient, employer, insurance, department, etc.?
You focus on the patient. That's the most important thing. Everything else is secondary. You focus on the security of the patient, you focus on their treatment, you focus on their recovery, and you try and you try and pave the way for them in those other areas. You make sure their employers realize that they need time off, that they need this attention. You try and act as an interface with the other issues that they may be dealing with. And that's part of your handling and being sympathetic as well as empathetic with what these patients are going through.
The next question is, I was wondering if you had any insights on handling cultural differences when delivering a difficult diagnosis. For example, in some cultures, it's customary to shield the details of a diagnosis from the elders.
Yes, well, I realize that, and that's why I stated that it's the line for being arrogant and being confident shifts from patient to patient according to their cultural heritage too, on how you deal with that. If the patient is lucky enough to have an advocate come in with them, sometimes they may not speak English, or if they do, there may be a cultural issue that he may not bring up, but which their family member, especially a younger family member, knowing the way we deal with issues in the United States, will be more familiar with, and let me know that indeed, you know what, my father's very sensitive about this, or please be careful when you use the word cancer. Sometimes you don't know what the cultural issues are, and you might inadvertently offend the patient, but you don't do it out of trying to be provocative with them. You do it out of the fact of ignorant and not aware of their cultural needs. So that's where experience comes, and I deal, especially in New York City, with a whole host of various ethical issues and cultural issues, and it's something that experience will help you deal with that too.
Great. And Dr. KJ Lee wanted to say a few words, so he was elevated to a speaker. Dr. Lee, can you unmute, and you are welcome to have the floor here?
Can you hear me?
Yes, we can. Welcome, Dr. Lee. Thank you.
Hi, I want to congratulate Dr. Persky. I think what you have done is taking very common sense pointers and putting it into a very profound scholarly lecture with a lot of gravitas. And I think rather than just a few of us listening tonight, can you or somebody package your talk just the way it is or improve on it, put it on a YouTube that every medical student in the country, every resident in the country should listen to your lecture once a year because they keep forgetting. Congratulations. I've heard a lot of lectures. This is a best well put, very profound, lots of gravitas.
Dr. Lee, I know your reputation. I know your stature within our specialty, and I thank you for those very, very kind words. Thank you.
Great, thanks, Dr. Lee. We have another question here. Non-English speaking patients deserve the same care as native speakers. Dependence on interpreters and language lines often depersonalize the patient-physician relationship. What is your approach to overcoming such a communication barrier?
Well, that's one of the reasons why I often, we don't expect patients to come with them, family members, but we certainly encourage them, especially if they speak English as well as their native tongue. So if a family member can come and be supported to come to the office, that's very important. Otherwise, if the patient comes and doesn't understand English, we have a whole host of interpreters that are medically trained to be as specific and as accurate in describing what I'm saying as possible. I don't know of any other way of communicating without either having someone in the family or having someone from outside who is trained in medical interpretation to help you.
Great. We don't have any more questions, but I just want you to know that in the chat, there are so many nice comments. A great presentation by a friend, colleague, and leader. Thank you, Mark. That was from Gadi Harel. And of course, Jeff Roach says that you were the best teacher he ever had. Cannot think of a better person to give this lecture. And also, I can't ignore my mentor from Ralph Metzen. Mark, great lecture. Congratulations. And to David and Marcia, an amazing tribute to your amazing parents. And so with that, thank you, Dr. Persky. I want to turn it over to David and Marcia to say a few more words.
Yeah, so thank you, Mike. On behalf of Marcia, the Edelstein family, and the entire Boston University School of Medicine community, I want to thank Mark for a wonderful lecture. I think he's captured the essence of the lectureship of professionalism and ethics. I couldn't agree more, both professionally and I would dare say personally, that honesty is an underrated virtue, something for all of us to think about tonight. And I would also say in your pantheon of wonderful people that came from BU is the chairman at my institution, Manhattan INEA, before me was Simon Prizier, class of 1960, who always said, set a high ethical and professional standard, high enough it may not be easy to attain, and then spend your lifetime trying to attain it. So these are principles we can teach the medical students, the residents and fellows. We realize that although we leave the medical school after 4 years, BU, like other medical schools, is still a place where we get wonderful education like tonight. Many thanks to Greg Grillone, the chairman of otolaryngology, Maura Coakley, Mike and Janine, and others at BU for making the Zoom conference come to fruition. And also, we'd like to honor our parents, Alan and Sybil, like most of us will honor our families and parents this week, who instilled the need for professionalism and ethics in our lives, our children's lives, grandchildren's, and for my 94-year-old mother, her great-grandchildren. So thank you for joining us today and having a lively discussion, lots to think about as we go home. And we look forward to seeing you again next year, and have a happy and safe Thanksgiving.
Thank you, David. Thank you, Marcia. Thank you, everyone. Greg, thank you. Michael.
Thank you. Thanks all. Have a happy Thanksgiving. Thank you.